So it's so wonderful to see some old friends and to see students back on campus and to have all of you here today. I'm Danny Fallon, current dean of the Rollins School of Public Health, and it's my distinct honor to have this conversation with two true luminaries in public health today. And this conversation really comes from what we as a community have all been engaging in for the last at least month and a half, 2 months. Many of you have been asking questions about what will a transition look like to a new administration. We also are in the middle of state legislative efforts, so there will be activities and public health related activities happening at the state level and then certainly at the federal level. We had a couple of conversations where we had faculty come in and talk about particular topical areas that we anticipate there may be changes under a new administration. But today we want to hear from two leaders who have seen lots of transitions and who can really give us their wisdom and insights around what we can anticipate and hopefully remind us that the work of public health is not going away. So let me start by giving you, I hope that neither of these folks really need biographical information to this audience of public health folks, but I'm going to do it nonetheless. So I first want to welcome Dr. Ann Schuchat, who was Principal Deputy Director of the CDC NP from 2015 to 2021 and served twice as Acting Director. Prior to that, she was the head of the National Center for Immunization and Respiratory Diseases at the CDC, and played key roles in the 2009 H1N1 pandemic, in the 2019 outbreak of vaping-associated lung injuries, and of course, in COVID. She's a member of the National Academy of Medicine. She retired from government in 2021, but currently serves on boards including Swarthmore College, Gavi, and the Vaccine Alliance. So welcome, Dr. Schuchat. And then, yes. And then the gentleman to her right may not need an introduction in this room. Dr. Jim Curran is a professor of epidemiology. More importantly, the past James W. Curran Dean of the Rollins School of Public Health, where he served for 27 years in the role. During that time, did many incredible things for this school and for public health, including leading the Center for AIDS Research here at Emory. Prior to that, many of you know he also served 2 decades at the CDC. From 81 to 95, he was the leader of CDC's HIV research and prevention efforts. And he also has served and continues to serve on many local and national boards and committees and is the chair of the board for the Georgia Department of Public Health still currently. So thank you, Dr. Curran. So the format for today, we're going to spend maybe the first 20 minutes of our time together with some just kind of open questions, me asking and hearing from our colleagues. And then we're going to protect, hopefully, the second half for your questions. And so those of you who are in the room, there are mics on either side. So when it comes time for the Q&A, please come on up. And we would love to hear what you're thinking about and be able to be responsive. And then we also have members joining us via Zoom right now, so welcome to our Zoom participants. And Dr. Lang in the back will be monitoring the Zoom questions, so people who are joining virtually, please also feel free to submit your questions via the chat. If we can get to them, we certainly will. So thank you for that. And with that, I'm just gonna jump right in. So I started this by talking about transitions and our anticipation of this transition. And so Dr. Schuchat, do you mind just sharing with us some of your experiences and kind of lessons learned or thought from your previous leadership during transition from a public health perspective?
Sure. Well, thanks so much for the invitation. It's so nice to see friends and colleagues here and those of you on Zoom. Thinking about transitions, I sort of did a little math and realized that my CDC career spanned 7 presidents, 9 CDC directors, 4 acting directors, including myself twice, and no 2 transitions were the same. The one thing I would say is that none of them were as good as we hoped, and none of them were as bad as we feared, but there's always a first. So the other thing about transitions, I would say, is that like pandemics, no two are the same. And so you want to prepare, but you want to be nimble. And for certain, the transitions that I was part of in leadership roles were very different than what the administration or the CDC director was really expecting. So you can go back to 2001 and remember that that was the year of 9/11 and anthrax, and really wasn't the highest priority for the administration or the CDC director at the time. In 2009, we were focused on health reform and getting ready for Senator Daschle to come in as the secretary. And of course, he didn't come in, and we got the H1N1 pandemic within the first 100 days of that transition. So we were lucky then that we'd been working very hard on influenza pandemic preparation. And really, that pandemic was milder than we expected, although very intense for the response and a big vaccination effort. But you can sort of guarantee that the pandemic or the transition you plan for isn't the one that you're going to get. In 2017, I would say that at CDC during the first 6 months of 2017, when I was acting director, one of our priorities was not to be the subject of a tweet. That seemed like that would be helpful, that we could continue to focus and we could keep doing our work, which we did. But during that whole administration, obviously the CDC did come under the attention of the White House and of the administration in many different ways. The other thing I would say is that there might be a desire to withdraw from the world, but the world is coming for you. And so in 2017, Secretary Price was there for just about 8 months. And during that period, I got to travel with him and his team to Liberia in recovery after the Ebola response, and to China in preparation for all the influenza issues that we were worried about, and to the World Health Assembly. And so the higher level administration might have been moving away from global issues, but the secretary wasn't. And so I think we have to almost wait and see what really happens versus what is threatened to happen. And what I recommend is just focusing on the work that needs to be done, the responsibilities that you have, your team, and recognize that there's a long-term need for public health that is undeniable and really important.
Thanks so much. The importance of our work doesn't change when transitions happen. Dr. Curran, do you want to touch at all on your experiences, under different administrations, or move straight into your thoughts on the current moment that we're in?
Well, it's an honor to be here in the Peggy room. And I think that it's great to be on the panel with Anne, whose experiences are more timely and more relevant than mine when it comes to government and public health. And after all, she's been on TV with Donald Trump. So she knows some of the people. I think a lot of us are just, I'm not in government anymore, so we're appalled by the nominees that are being proposed in the health arena, independent of how else we feel politically. But, public health is always political because we deal with populations and we have to have the populations with us. But it isn't always partisan. And a lot of us would say we wish it were never partisan. And even when it's partisan, it's not completely partisan. So a lot of times what you think is going to happen doesn't necessarily happen. Now, I think I'm still hopeful that Kennedy won't get confirmed because he's the most painful one for me. But many of the other people are going to have to decide on individual issues. And a lot of times individual issues are not the same. So it's important to separate big P politics, that's partisan stuff, from little p politics, is what the public wants, and then try to link those two up. For me, I guess the greatest political involvement was in 1981 when Ronald Reagan beat Jimmy Carter, another one-term president who didn't get the public vote. He didn't get the public vote in part because of the Iran-Contra event, but mostly because of high inflation and high unemployment. And the people didn't like the way the economy was going. And in general, people want to throw the bums out. And I think whatever you hear about Biden and Harris, the country wanted to throw the bums out. And that's been done throughout Europe and many other places. There's just a transition to a different type of politics that is dealing with certain things in the public opinion. And the things that got Trump elected have almost nothing to do with health. So think about that. It's really immigration, inflation, what else, right? And throw the bums out. So that means that the short-term politics is going to be really important. Now with Reagan had no interest whatsoever in the beginning of the AIDS epidemic. And he had some distinctly homophobic people working for him, which means that they had even less interest in the AIDS epidemic and gay people. But other people in the country cared about it, including the Democrats and including public health people. And eventually the tipping point was that the sight of thousands and thousands of young people dying who happened to be gay men awakened the conscience of the public to saying that this is more important than our prejudices and even more important than partisan neglect. And so things changed. And then George Bush, of all people, expanded PEPFAR to providing care to people all over, particularly in the lost continent of Africa that supposedly we didn't care about. So there's a lot of ways you can kind of see how different top politicians will do things. And then also having a good politician in, like we think the Democrats, didn't get us anywhere with needle exchange or gays in the military. It brought us don't ask, don't tell. And I got called on the carpet quite a few times after Reagan was out of office for promoting needle exchange or talking about needle exchange. And so the thing is, you can't always predict everything that happens based upon this. And then always remember that politicians themselves never think long term. They talk about it when they get really old, but they don't think about it when they're young. They think about the next election. And the most important thing to Donald Trump is going to be approval ratings. And also his own voice. He will be the Surgeon General. I mean, he's going to be the one who talks about everything. And therefore, we've seen this already with his reluctance to on a national abortion ban, with his promise that he won't get rid of vaccines, a weak kind of promise, with the idea that he won't cut Medicare. So he's doing, he's already changing his mind, thinking about the short-term politics, the little p politics. So I think that there's a lot of reasons to distrust, particularly Kennedy. I think the other people will be very malleable in their jobs, if unqualified, but malleable, to meet some of the programmatic priorities.
Thanks so much, Jim. Both of you have had, a career of being a part of and leading both public health workforce and to some extent academic training for that public health workforce. Any advice or thoughts you want to share with many of the folks in the room, are students or are part of the public health workforce in this moment in time that would be, particularly useful or that you think would be helpful for them?
Yeah, I can say a few things, and then I think obviously Jim had a much greater role in training, but I think the issue of misinformation and disinformation and truth and evidence is very prominent right now. And as students, you're going to be helping create a record of scientific results, and also hopefully learning to communicate that effectively. the ways to communicate, both the methods and the style have changed so much since, I got into this world. But I think your generation of students really can be leaders in that space. The idea of, a few networks or a few spokespeople driving the conversation is gone. I think feel lucky that most of the time that I was at CDC had a pretty strong and clear voice, but we can't always guarantee that. And certainly in the beginning of COVID, we weren't able to do much communicating. And so I think Emory students, researchers have a huge opportunity to be both developing evidence, communicating it, and communicating it simply, clearly, and in ways that are persuasive. So I'm big on data and measurement, but also on communicating and connecting.
Great, thanks. Jim, how about you, particularly in the context of academic public health?
Well, I think, it's important to think about why we are where we are. And I think a lot of that, one of my favorite aging authors is Robert Putnam, who wrote Bowling Alone, and he's written other books about the trends in social capital over time in the United States. And a lot of times accomplishments are given credit for things that social capital helps. And right now we're at pretty much of a low in terms of social capital in the country. We don't trust government. We don't trust institutions. We don't trust mainstream churches. We don't trust the press. Therefore, we don't trust science, and we don't trust anything. So I think if you single out one area of distrust, you got to remember it's in a big sea of distrust of everything. Everybody, relies instead on social media, where they can find an echo chamber that they trust. And that explains at the biggest extreme why a probably psychotic young man can shoot a healthcare executive and be applauded throughout the globe by it. Because people are more concerned about the cost of healthcare and denials than they are about the psychotic, crazy man shooting somebody. Now, a lot of us, you get older, put it in a different perspective. But that means that one thing we have to do is work in an area where there's little trust. Now, I know that, the school is really beefed up its communication capacity, and all of us have struggled with how to use social media, across echo chambers. But the main thing is to recognize that the public is not big on trust. So that means they're not big on mandates. They're not big on concepts of improving the health of others. That you need to do this because it'll benefit society. They're more likely to hear, what's society doing for me? They're not that big anymore in identity politics. That's why the crashing of DEI programs through our country is partly because people are tired of programs aimed at identities rather than different kinds of problems. That doesn't mean they're right or that I approve it, but it's a recognition that identity politics by itself won't be enough. It's also dangerous to ignore it. You can say, well, we don't care about the gay community, but we want to work on AIDS. Now, wait a minute, That's not identity politics, but it's also recognizing that both groups need to work together, not simply for the identity. You need to figure out a different way to frame the problem to accomplish the goal, because people do really care about the public health goals. That's the encouraging thing. Nobody wants to die. Nobody wants to die young. Nobody wants anybody else to die. Nobody else wants something to happen. So, for example, and surveillance itself is the shining light of what happens. So we're going to see more and more, if the data can be presented, more and more examples of things that people don't want that other people may want to prevent them from happening. We've already seen maternal mortality issues related to illegal abortions or problems with abortion laws. We're going to see lots and lots and lots of problems with healthcare access denials. And we need to shine a light on those things because those are the things the public actually care about. You know, they don't care about, we got to make sure everybody gets health care, but they do care about examples of lack of health care. So we need to kind of reframe a lot of these issues along the lines of things that people really care about.
Thank you so much.
Just in a comment, I heard Robert Putnam speak recently, and you know, it's been 25 years, I think, since his book. There's a new documentary about him, but his you know, he's I think he's an optimist, even though his work is very pessimistic, and his you know, prescription for us or for the world right now is to focus locally. That you know, that to build where you are, to work where you are, to get to know your community, because one of the things that is so difficult about social media and the virtual world is that trust factor. But locally, as you get to know neighbors and get involved and, you know, do whatever, you start to rebuild trust.
His most recent book is Upswing, which he published when he's 80 years old. And it's about the idea that the decline in social capital that we've seen in the last 30 years or so is ready to go back up like it did in the 1920s or 1930s, and that we'll be back there again. And that means that the thing to do now is do your best job. Now, you know, if you have to decide what your role is, you're a citizen and you're an employee, and where you're an employee. You can work at a nonprofit. You can work for government at any level. And if you're a citizen, you can, you know, lobby and vote against anything you want to lobby and vote against or for. If you're an employee, you have to play the game a little differently, because you may, you know, it may be seen as going outside the boundary of government. I'm chair of the Georgia Department of Public Health. I personally think it'd be very good if Georgia would expand Medicaid. The guy who appointed me, Governor Kemp, doesn't agree with that. So I shouldn't go on a talk show in Georgia doing that. Otherwise, I'm, you know, cutting off Kathleen Toomey's ability to deal with public health in Georgia. On the other hand, if I step down or I get kicked off, then I can do anything I want to do. So the thing is, you know, plan for the upswing. Realize the public health problems are going to get, you know, even more complicated in the future. They're always going to involve populations that have to be on the side of us, that need to be communicated with. And the other thing is, do the best damn job you can do. And, you know, I can tell you, being old, the best thing you can say is that I worked hard all the time trying to do what I can. And if you do that, you'll succeed, and what you're working on will succeed.
Yeah, I think just commenting on that, I think we're so lucky in public health because what we work on really matters. And hopefully we can work on issues long enough and hard enough and effectively enough that we can make a difference. And I think, you know, whether we're really going to have an upswing or we could just hope we're going to have an upswing, I think you know, we have to believe it and we have to work towards that. And I do think that there's a backlash now on like the virtual world, you know, the issue of what technology is doing to kids, and that idea of having meaningful work and having work that matters is going to be in the ascendancy. I think there's you know, whether it's quick or slow, I don't know. Whether it'll be by the midterms, I don't know. But I think in public health, you're really focused on things that make a difference in people's everyday. And you can feel good about that. Or you should feel good about that. You might not feel good about it today, but you should feel good about it.
I think Anna will recognize this, but I know Bob Pinner would. There used to be a time many years ago when people thought that they mistrusted government, but they trusted the CDC because they didn't think that was part of government. And I think that's partly because they didn't want it to be part of government. You know, they wanted the idea that somebody they cared about, who they trusted, was not related to government. And I think it tells you that in the long run, you know, the current feelings about CDC are going to change again because of the kinds of things that people at CDC do.
I think also, it's easy to be in our bubble and think, the world is falling apart and everything's terrible, and even the CDC reputation. I'm involved, as you heard, in Gavi, in the global vaccine work. And in other countries, and to people working in public health around the world, the CDC is still very much respected. In a lot of communities, in a lot of states in the US, it is. In, the White House, maybe not, in the future White House, but I think that there's a lot to work with, and a lot, I know my friends who are still at CDC, it's been hard. It's been a really hard time to focus on morale, to feel good about the place that you work and the reputation. But I think there's still, there's a lot of good out there, and a lot of trust that we can work to build further.
Thank you both. I hear themes of lean into our passion and purpose of public health. Be tenacious, work hard, and optimistic, even intentionally, when it's intentionally. So, as promised, the idea was not so much for me to ask questions of our two guests, but really to hear from all of you. So if you have questions in the room, please feel free to come up to the microphone and ask what's on your mind. And then, as I said, Dr. Long will be looking to see who on Zoom might have thoughts. Anyone want to be bold enough to start? Yeah, come on up. Please come to a microphone because of the folks on Zoom.
Hi, thank you so much for being here and talking to us students. I really appreciate the opportunity to learn from y'all. But you mentioned Robert Putnam and the bowling alone and social capital, and it makes me think of what has been declared a loneliness epidemic in the US. And I'm curious about how public health can address a loneliness crisis, and how something as intangible as loneliness that's not, detectable on a PCR test can be talked about in public health spaces and hopefully addressed and programmatically corrected.
It sounds like something for a mental health expert on the panel, Dr. Fallon.
I can start, but you're here to ask questions of these folks. So if you haven't seen it, the Surgeon General not too long ago put out a report on the state of loneliness and activities that we can do, including what I thought were maybe obvious but important suggestions for workplace mental health in the context of loneliness and for school-based loneliness. And they are really, in some ways, obvious things like ask people questions about themselves. Like, it feels a little weird, but in fact, these are skills that we've kind of lost some of our muscle memory about doing. And so there is an evidence base growing now about how you would do these at a public health scale, at a sort of organizational and structural scale, to promote connectivity and combat the harms that loneliness can cause. But again, you're not really here to ask me questions. So if either of you have thoughts on this, please.
I was going to tell a story that you reminded me of. I was in a hospital visiting my mother with my sister. We were in an elevator, and I was working like 24/7 at the time, and said something in the elevator to her about, I'm always working, and I really have no social skills at all. And a woman in the elevator, overhearing it, said, "That can be taught." So I do think that, we can be obsessed with what we're doing or working or just engaging with people like us, and that ability to start to feel comfortable. I mean, I know people were telling me they had trouble, knowing how to make a phone call. You were just texting all the time, knowing how to, start a conversation with a stranger that you needed to talk to. And you might experience that in another country when you're not comfortable with the language skills, but here, practice is important. So, but I do think that issue of the Surgeon General report, there was a lot of, backlash even of that, of the language and the teasing and so forth. But I do think it resonated with a lot of people in terms of a call to action.
Thank you.
Thank you.
Thank you for being here. I wanted to take off on the point that you just made about one of the things that's wonderful about public health is that what we do really matters. I think the other challenge in public health, though, is that if we're successful at what we do, often the outcome is something averted. it's not something that happens. So the success that we have sometimes is invisible. And sometimes it could also mean, as we have success, it leads policymakers to think that we no longer need to fund that because that's no longer a problem. What would your advice or thoughts be on dealing with that our success means that we're actually less visible in some way?
Yeah, I thought about this a lot when I led our immunization center, and I actually got our graphics people to make me a slide that was, I'll describe it, but basically the Andy Warhol, Marilyn Monroe image that is just unforgettable, basically. I had them turn our graphs of disease going down into the Andy Warhol display, and I think that's the fundamental thing with vaccines, that, when they work, you don't see them. But we do have some successes to build on. I think it may be hard to remember now, but at the beginning of the COVID vaccination, so many Americans had that joy of being able to get a vaccine, whether it was in a stadium or a pharmacy or wherever, that they finally got it and they really wanted it and they knew that was going to be important. The actions that are involved sometimes can be memorable. With group B strep infections in newborns, we're preventing a lot of disease that you don't see now, but women are getting screened prenatally. And so it's a regular thing that they get reinforced, that there's something that, they're testing me for that we can prevent. But I think it's a challenge for both language and measurement, to be able to talk about what's averted in a way that doesn't sound like economics, but sounds tangible.
Neil, I think what you're suggesting is a huge fundamental problem that we have in public health. And your background in TB and my background in AIDS suggest a solution. Because unlike other infectious diseases, which can be controlled by vaccines quickly, and we focus just on vaccines, the poor links between clinical medicine and public health were reflected. I mean, nobody cared about preventing HIV in the communities that had it unless we were treating people with HIV. And nobody really cares about preventing TB unless you treat the people and don't let them die. And that's the same thing that's going to be true for chronic diseases. It's not enough to just say, quit smoking, exercise more, get a diet, and forget about whether you can get diabetes managed, whether you can get Ozempic, whether you can get cardiovascular disease help when you need it. There's got to be a much closer link between clinical medicine and public health. And it's conceptually easy to do. And that also involves health policy. If you don't have coverage for a lot of the clinical care, then, what does prevention mean to people? What they care about is not dying, right? And having a good quality of life. And, okay, don't let the kids smoke while grandfather's dying. So you got to tie these together somehow or other. And I learned that early in AIDS when Larry Kramer, who was a famous activist in ACT UP, was on a show with me, and he started out by saying, what Dr. Curran does is irrelevant. Because I was the prevention guy on the show. Talk about the people that are dying and what you're doing about it. And I think that's true for breast cancer. I think it's true for diabetes, heart disease. It's true for lots of things. Drug overdoses. We became interested in that when it became much more democratized and people were losing their kids. And what they want to do is stop losing their kids. And so we need to think more broadly and be engaged more. Diets, what are the recommended dietary things, Well, what does public health think about GLP-1 inhibitors? And should they be made available? I tell you what I think. I think Biden was very smart by proposing that Medicare pay for them before Trump could come in and stop it from happening. So now Trump's got to go against public opinion. And this may be one of the miracle drugs of our time. Now, other people disagree, but that's how I feel.
Thank you both. I'm going to make sure that I cover both sides. So why don't you go next?
Hello, thank you for speaking with us. And I think my question is a good segue of what you were already talking about. But as we know, public health is a quite a multidisciplinary field, but what silos do you still see that we have that we need to integrate, and what are some solutions to that we can incorporate in our day-to-day academic lives?
I'm not sure I heard the entire question. That's my excuse.
I can repeat. I was saying, what silos do you still see within public health and the broader academic community, and what are some solutions that we can have for our day-to-day academic lives?
Well, but I already mentioned the medicine public health silos. I think, and you know a lot about the community issue silos. I mean, I think a lot of times we think that when we discover the solutions, all we have to do is prescribe them, and then people will follow them. So part of it is the silos of working with individual populations, which has expanded greatly when you talk about global health, as well as U.S. public health. And then the question is, what skills does it take to engage those populations and communities? And the skills are partly, engaged in medicine and epidemiology, but it usually involves different kinds of disciplines in addition to those two, and also involves the ability to work with partners. So I think that the silos can also be identity based. In other words, I really care about minority health, and I'm interested in diabetes. Well, you should be care about everybody's diabetes, and you can focus on one thing, but the program's got to be broader, if you will.
I think there's also the perspective of the funder, and involved in Gavi, we're really focused on vaccines, but we do have health systems as part of the portfolio, and there's a huge desire on the part of the countries for there to be better coordination and harmonization between Gavi and the Global Fund and other major global funders, because at the front line, they're trying to make things work. So I think that sense of what's the use case and how do we bring the fields together, whether it's funders or disciplines. The other thing your question reminded me of, when I worked on vaccines, I was very excited about HPV when it came out in 2006. And I remember going to, I think it was Nevada, and meeting with the district level health officers. And I said, we have this big initiative at CDC. We're getting the cancer people and the STD people and the vaccine people and the surveillance people all together so that we really have a unified package. And somebody said to me, I'm all those people. It's not, that's your problem, not at the frontline delivery issue. I have to do all those things for my community. So I think that whether we're doing research in one field or a public health program, remembering it, whether it's the clinic or the street, what's the public going to see, and how do we bring those together?
One of the other questions is, how do you awaken the silos and awaken the causes of such diversity? And I want to give Jenny Bales Harris here a little bit of credit for the ingenious starting of the behavioral health surveillance systems, which involve schools. When people were saying, because everybody cares a lot more about kids than anybody else. And when you start to find out the kinds of things that kids have, and also the kinds of things that behaviors that kids have, that awakens the public to what's happening. And to find out that it's happening in your state with this kind of information shining the spotlight on these problems was a key thing that CDC embarked on, and it's continued to embark on. You can tell it was good because it's gone on for over 40 years now. To awaken people to the kinds of problems that are public health problems in the future. And that's extremely important.
Thank you both, and thank you, Jim, for bringing that up. I was going to take license to just answer it because I can't help myself. The gap between what we do in physical health and in mental health from a public health lens is something that I'm passionate about as well. So thanks for that question. Dr. Mo.
Yeah, thank you, Dr. Schuchat and Dr. Curran, for coming to talk to us today. I'd like to go back to the question of communication and trust and speaking truth to power. And Dr. Curran, you gave the example of Medicaid expansion. And Dr. Schuchat, I know you were a leader during the pandemic. And when is it wise to speak the truth to power, even if the truth may be bad news? And when is it wise to keep your mouth shut? Because I think we're going to be encountering a lot more of this in the next few years at multiple levels, at university, at state, at national levels. What do you suggest based on your experience?
Yeah, I mean, I think that everybody has to make a personal decision and then maybe an internal lens of what's my role, what are my opportunities, where can I have impact. I have to say, certainly back to that White House press conference, it was surreal to be thinking about, I have the whole world's attention in that microphone. And there was sort of a funny moment before that press conference started that there was the group was all together in this, in the cabinet room, I believe it was, and Secretary Azar was explaining to the president what was the run of show of this event. And he said something about, I'm going to talk, you're going to talk, then so-and-so is going to talk, then I'm going to talk, and then Dr. Schuchat here is going to talk. And the only other woman in this room of 20 people was Kellyanne Conway. And she was at the other end of I was here and she was at the other end corner of the table. And her eyes just went, because she had no idea who I was, what I was going to say, this microphone was going to be handed to me. But anyway, when it was my chance to speak, I was thinking, what do I say? I'm representing CDC. My audience is the American public, and what do they need to hear in this moment about the pandemic and how to prepare and turn everything else off rather than, make a political statement of some sort. When we weren't allowed to speak, when most of the CDC wasn't allowed to speak anymore, I thought a lot about what could be my role. And I felt like we have so much, the pandemic is so bad. CDC has so many resources right now, human and financial, and the states need us. And the most effective thing I can do is support our people to support the state and local health departments who need us. And, my trying to make some statement about what I think is or isn't right isn't really going to be very effective. But others might not feel the same. I know a lot of state health officers felt like you do with Governor Kemp, that I can have more impact within than outside. Whereas others, personality-wise or what they had access to, they felt like they could be more effective without the official role. Sorry, it's a sensitive topic.
I think speaking truth to power is really important. And of course, the professor behind you is known for speaking truth to power in the prison areas. And so the thing is, a lot of it depends on what position you're in. The position Anne was in is that she was the power. So, she could speak above herself, but most of the public thought the director of CDC is the power. And therefore, look at Tony Fauci, who's been decades and decades of speaking the truth, or at least the truth as he knows it at the time. And yet he's the one perceived to be the power. So a lot of it depends on how this lack of trust works and how to do that. And of course, if you're inside an organization, you're different than if you're outside. And one of the great things about our country is we have a lot of people outside of government who have a voice, because otherwise the government could just go on unchecked. And I think we're going to see a lot of outside government voices in the next few years on a variety of different topics. Some of them will be outrageous, as was ACT UP in the AIDS epidemic, when they thought that, St. Patrick's Cathedral should be carpeted with condoms. But they got people's attention. And then when they got more educated about things, They got people's attention, and when people were listening to them, they actually could change policy. And that's because the small p public cares about the issues. They don't wake up in the morning and say, I'm a Republican or I'm a Democrat. They wake up thinking about issues that care to them.
Thank you so much. I know you've been standing for a while, but Delia has been very politely waving to get in one of the online questions. So if you don't mind, we'll ask an online and then we'll go back to you.
Thank you. So we have a couple of online questions. I'll start with one to both speakers. And the question is, as you've repositioned yourselves in your careers and perhaps moved away from attachments to different or major institutions, do you advocate for public health issues that you are passionate about differently than before? And if so, what does that look like right now?
Yeah, maybe I'll just do a quick response there. I'm still a newly recovered government employee, and I have a lot of, reporters have been calling me because of the transition about some of the vaccine issues in particular, and I'll think, oh, I can't say that. And then I think, well, I can say that. And then do I want to say that? Or, I think to some extent, some of my credibility over the years, if I had it at CDC, was that I was nonpartisan and that whoever was there, I was for the public's health, and I was, that was my role. And I tried to make sure that, especially for the employees who came from all over different perspectives, that I wasn't off-putting, that I was, a nonpartisan leader, a public health leader. So I think that I'm still figuring that out in terms of the voice part.
I'm a long time retired from the government, but I'm not very long time retired as dean. And I think it's important to think about the kinds of influences you have, the kinds of factors that influence you. So, for example, you can be a very passionate faculty member, but you're listening carefully to what the NIH priorities are in your area. And you may not want to criticize NIH, even if you think they might deserve it. And a lot of times we have a combination of making excuses why we don't advocate for more things or more broadly, and partly because what is our personality type like? What do we really like to do? I know several people retired from Emory and CDC who've hit the campaign trail, and that's what they want to do. They want to get out there and campaign for the political candidates that they believe in most in, and they find that energizing. I don't find that energizing. I care more about the public health problems themselves. Recognize that some of these people that are elected are not going to be on my side. But I also don't see any real expertise I have in not getting them elected or getting someone else elected. And I don't enjoy it that much. I'd rather sit back in my house and bitch about them. But because I'd rather advocate for conditions and things I like. And for me, a lot of that's the public health workforce and improving the quality and compensation of the public health workforce. Making sure we have highly qualified people to enter it. I mean, one of the things I'm most proud of as dean is how many people we have working at CDC that went here, who have been hired and valued there and do this. My daughter works there and she hires people from here. She didn't go here, but she can't hire some people. So the thing is, I really care a lot about that. So I advocate at the state government for more pay for public health employees. And strategize to try to figure out how to do that. But I think you have to know your own position, even as it continues. And then also your energy and other things as you age. There are some people that retire at 65 and they're retired and they want to go do nothing to do with anything to do with their work. I'm obviously not one of those people, but there's a certain amount of energy you could put into things.
Thank you. Why don't you go, and then Delia, if we have time, we'll do one more online. Yeah.
So this is kind of a segue to what Dr. Mo was saying about speaking truth to power. And the thing that really worries me, and I'm sure that my luminaries here will explain how to deal with this, but I really worry about a trend not to recognize truth. So in a campaign that's marked by people asserting that Haitian immigrants are eating their pets and repeatedly hearing that, is there any objective truth? How do we deal with a, I guess, postmodernism atmosphere where there is no truth when we are a science that depends on people recognizing objective truth?
Yeah, I mean, I think that was part of what I was trying to get at earlier in terms of the local work, because I do think people will believe anything on the internet. Certainly there's a fringe that will believe anything. But part of the reason that a lot more people are believing stuff is because of where they're getting it. It's their network that they've started to trust over soccer or over church or something. And now they're, being forwarded something completely ridiculous. So I think the actual in-person local people that are going to be more influential in the future in helping you differentiate conspiracy theories from reality. In vaccines, a lot of what we've talked about is the conversation between the doctor, nurse, pharmacist, and the parent. That yes, people come in with all kinds of stuff, but having a conversation that is respectful, empathetic, listening, what are the concerns? Now let me listen to that and have you start to trust me because of the way I'm listening, and begin to tell you what I know from my experience, which is XYZ. That recipe is actually pretty effective, whether for the things that matter, for the local, the decision about your child, for the Haitian dog situation. Really, it's back to Putnam and the upswing and hope that the local work will help. So,
I think one of the things that all of us think is really important is that what we do is science-based. But I think that the term science has mixed views. I mean, first of all, a lot of times if there's something we're unhappy about, we say they're going against science. And it's a little bit tricky because, if you're in the university, the only science that counts is in the laboratory. But if you're we want to pretend that we have enough information to know whether we can keep kids out of school, and that's totally based on science. When in fact, there is some scientific thoughts behind it and some scientific information, and we're going to act with the best we can, but it has to blend in with other things. And so if we don't like the answer, like we're going to keep kids in school because of educational issues, we can't say it's anti-science, because science is incomplete sometimes, and it's also changes in terms of scientific findings. So I don't like it when people say, this is what science says, you're wrong. When a lot of times it's an incomplete evaluation that, come back to see us. And that was one of the problems with COVID, is that people were acting on the best judgments they could during a horrible pandemic. But then some of the information changes over time, and that leads to a dissatisfaction or a distrust, even further distrust of, for example, vaccines, which were, not as good as we thought they would be based on the initial trial, but were crucial. And, how do you explain the difference there? Science didn't change, but the evidence changed, and then people have to be ready for that. So I think we have to be careful when we're ourselves are not mixing up science with politics. If there's something we don't like some of the nominees for the current administration, if we just say they're anti-science, I mean, they can be despicable without being anti-science. So we shouldn't always use the term science. We should just say they're despicable.
Well, so far I've heard from each of you, transitions are not what we think they will be. We can always anticipate that. That we should separate big P from little p, that we should continue to build rigorous evidence and our communication skills, and hope that we're providing the right fodder for that upswing that we anticipate. Those are your words reflected back, but I'd like to give each of you the chance to leave us with some parting thoughts, if you'd like, as we wrap up.
Sure. I think being prepared but being nimble is important, focusing locally. But another thought is just to get out, to get outside your bubble, your friends, your discipline, out in nature, out of your head, and realize it probably is going to be a long 4 years, but public health needs you for the next several decades.
Working in public health is unbelievably terrific. It's you're constantly redefining the unacceptable, if you will, to come up with possibilities to improve the health of lots of people. And in order to do that, you have to really understand it. You have to understand all kinds of different sciences. You have to understand medicine and health. You have to understand vaccinology. You have to understand people and their various needs in various places. And then you have to work with diverse people so that your work itself is enjoyable diversity. And you're always doing something which can potentially help others a lot. So, I mean, what a great thing to be able to do in the future. Politicians decide the problems are going to be there, and people will care about the solutions, and they will hold even the most despicable members of government accountable if it doesn't happen. So I wish I had another 30 or 40 years to do this.
Well, thank you both so much for taking the time to share with us today. We're really appreciative. Thanks. And thanks to all of you for being here.